Hello everyone, welcome to our 7th video lecture for Sociology of Health and Well-Being. And for this session, we'll talk about physicians and allied health professionals and the social realities that surround professionalization in medicine and allied health. So we're going to be talking about the evolution of professional medicine in our sources. We'll really talk about a Western history, particularly an American history of it. But as we have already learned in our previous sessions, that the evolution of particularly the professions in the West kind of mirrors the Philippines, particularly because many of our public health and professional health institutions are very much patterned in the West, but we'll also have some discussions about changes or peculiarities that are found in our local setting. And then we'll talk about the physician and patient relationship. What are the different social and psychosocial factors that influence the nature of that relationship, the goal of that relationship, and the outcomes of that relationship. And then we'll talk about health professionals that are outside the physicians or the doctors. We'll talk about nurses, and also we'll acquaint you with the other people in the healthcare system that also do a collaborative work in order to make the populace healthy. So first, we have to look at the historical ascent of the professional dominance of medicine as we know it already today. So if you think about the physician today, and you are going to sort of think that it is quite an influential profession in society. But in the 18th century, physicians were frequently relegated as non-producing classes, or they possess little more social capital than, just the same as marketers or tradespeople. And during this time, their knowledge was often regarded as dangerous, and their market position was considered precarious. And there was always this competition with during those times, family-based and traditional healers, and particularly because during this time there was still a lot of religious influence on the healthcare delivery, right? And then eventually, the transition from this low prestige vocation, and probably you might have already watched and maybe have been wondering, why, for example, in Jewel in the Palace, si Jang Gyum, the position of head chef was actually considered higher in the social hierarchy as opposed to physicians. So when Jang Gyum moved from working in the kitchen to moving to the medicine, it served as if a downgrade in the context of that particular culture. And we can also sort of think that somehow that also happened in the US. Not to say that, cooks during the time was, of higher regard. It's just that physicians didn't have the same prestige as they do have today. So the transition from this low prestige vocation to the professional dominance that we have today in the 20th century was not a natural byproduct of, scientific progress. We talked about this, germ theory being pasteurization, the asepsis, surgery, etc. But it's also because there is a deliberate professional project that has been done, particularly in the United States. This involved a strategic closure of the medical market, specifically by marginalizing and eliminating competitors such as apothecaries, midwives, helots in the Philippines in particular. And when we look at the history, particularly by the medical historians in the Philippines like Mercedes Planta, you would see how the colonial project in the Philippines has noted that these traditional healers were considered to be unhygienic and therefore contributed to the different illnesses that were present in the Philippines during that time. And so we inherited that as a part of the colonial project. And so what happens is that the state endorsed this particular monopoly over licensure in education. And this is what Ayala, Sociology of Nursing, considered as inheritance. Like, it is only doctors who are allowed to educate doctors and produce new doctors. So it became a lineage. It became a very exclusive profession. And to get there, you have to be trained by them. And so there are no more competitions. There were credentials were set up, right? And so what happened was there was a consolidation through the form of licensure. And maybe you have heard of this particular societal practice of licensing someone in order for that person to have some sort of positive sanction. Yes, you are allowed to perform a particular profession, or probably drive if it's like a driver's license, right? So credentializing is an important seal that says that yes, you are a professional. There's a particular professional boundary and scope that you are allowed to do, and you can get economic gains from. And that, of course, happens in a lot of professions we have. And maybe you will learn that in the sociology of work when you get there. And so there also had become a standardized science-based education. And so what had happened is, in the context of during this time, alongside, there was a huge orientation with Popperian philosophy. I don't know if you remember Popper in the science and technology and society classes, but there is a large support for that. And so falsifiability became a thing, the scientific process became a thing, objectivity became a thing, and that also became the compass of what was true in the context of physician training and physician practice. And this is what Elliot Friedson mentioned as the professional dominance, meaning the creation of a profession to dominate a particular field of practice in a society so that they are the only ones who have a monopoly over a particular practice. And so at the same time, we also get to concentrate any economic gains that come with that particular practice. So the physician or the medicine or the medical profession was one of the also a very good case, not only of sociology of medicine or sociology of health, but also the sociology of profession, that particular story. So maybe you would ask, what is the difference between a vocation, like for example, being a priest or being a nun, as opposed to being a profession? And according to William Good, there are three criteria or three indicators that separate a vocation from a profession, and that is one, rigorous standard. So in order for you to enter into that particular profession, you have to have intensive formal and informal socialization, usually in the context of formal education, higher education, for instance. And then there is significant autonomy. It means that only the people within that profession is allowed to, dictate the guidelines, the professional standards, the research standards in that particular profession. So autonomy is very important. And finally, prestige and identification, meaning you say it is a profession because it is, like I said, it is enjoying high social standards, and then it facilitates income by totalizing a professional identity, and it usually is deferred to them in their lifetime. It becomes a part of their identity as well. So those are the three things: standards, insignificant autonomy, and prestige identification. And then what does autonomy mean also? So there should have technical knowledge, meaning these are esoteric skills that are not available to a normal lay person who was not inducted into or socialized into that particular profession. And also, there's some form of credentializing before you get to that. Like, for example, in our case as nurses, right, I may have the same training that I have with another, Bachelor of Science in Nursing graduate. But if that Bachelor of Science Nursing graduate is not able to demonstrate their technical knowledge through passing the board exam, they aren't allowed to practice because they won't be able to receive that license. So that sort of entry. But it is quite interesting because the license or passing the board exam doesn't necessarily mean that you can practice perfectly. Like, for example, I have a license, I still get to renew it, but you put me in a clinical situation now and being a little bit far away from my practice since I, entered the liberal arts departments. I would say that I would be less confident than a new graduate of a Bachelor of Science in Nursing who may not have a license yet in terms of performing in the hospital. So again, it's really that in those particular ritualistic activities, credentializing, that separates a professional from a non-professional. It's not really to say that you have good skills or bad skills. I could remember, for example, I had classmates who weren't nurses yet, but they were acting as if they were good nurses in the hospitals when we were doing, for example, surgery. When we were assisting surgery or when we were doing rounds in the wards. And I would wonder why, but because they were, they owned their parents owned hospitals or their parents were nurses, so they had more training, but they weren't considered professionals yet, even if they did as well as the professional nurses did. So it's very important that somebody has to credentialize you to get into that particular profession, and so that's very important. Next is also that service orientation, based on Elliot Fridson's model, that looks into it, and so there is that silent message that professionals are supposed to be altruistic. They're supposed to contribute to the quality of life of if the work that you do doesn't really contribute to the quality of life, whether that's an engineer, whether that's an agriculturist, whether that's a chemist, you're supposed to be contributing to a dimension of quality of life of someone. And there's always that conversation about, I have to go and, provide service more than my self-interest. So you would have these ethical codes. But of course, we do know that in practice, that doesn't really happen. And also that is both detrimental to the one being cared for and also the one who is providing the service. Because if you're already burnt out and you already don't have the faculty to do so, and you're still tethered into that particular code of ethics, that you're supposed to perform and be altruistic and be service-oriented, and that's going to be quite, detrimental. And then we have self-regulation, as I mentioned, doctors produce doctors, nurses produce nurses. They are the ones producing all of these entry points for you to become a nurse, for you to become a teacher, for you to become a social worker, for you to become a physical therapist. They're the ones setting up these board exams. They're the ones checking these board exams, and they're the ones certifying that you can still practice, etc. After 3 years in the continuous professional development law of the Philippines, you're supposed to have this amount of exposure to continuing professional education through probably seminars, or in my case, I do research, and that's my continuing professional development. I have to submit it to the credentializing body of the Board of Nursing, and then they say, you are allowed to still have your license and practice for the next 3 years. So there's that idea of self-regulation, and it is not someone external doing that. Supposedly, the body that self-regulates also comes within that, from within that profession. However, in the contemporary times, we've seen that professional dominance and authority have eroded, and there are three theories that sort of contribute to that decreasing professional dominance of physicians in our society. And the first one is, according to Light and Levine, is corporatization. This theory posits a clash of two cultures. Traditional medical ethic of being patient-centered care has been intruded upon by a commercial ethic. You're supposed to be earning. Your patient is supposed to be paying for them to receive care. And we see a lot of that in the American society, right? As medicines becomes more high-tech, becomes more high-cost endeavor, it required corporate infrastructures, like you have managers, insurance adjusters, you have CEOs who effectively subordinated physician autonomy to organizational efficiency. And so the managerialization of hospital organizations, right, had contributed to the decreasing autonomy or the decreasing dominance of doctors in their own practice. The second one is the professionalization by Marie Hogg. Hogg argues that the monopoly over medical knowledge has already been fractured. The democratization of information, just as, for example, you are accessing WebMD for your symptoms, you Google your symptoms, you chat GPT your symptoms, you asked, and sometimes you go to the doctor in the outpatient department, and then you ask your doctor directly, this is what WebMD told me, is this true? And then when the doctor tells you that, I don't think that's what you are having, but we have to rule that out, and you say, no, I think this is what I'm feeling. And of course, there is some hypochondriac thing happening there. But yeah, so medicine has, the internet has the professionalized nursing, the democratization of information. Although there are two sides to this, no? Of course, there's always that, that the information in the internet, you're not necessarily sure whether or not that is going to be true. And of course, the problem with, misinformation is that it travels faster than nuanced, correct information. And then, of course, we have heard this term before, and we call it the infodemic. And this is, of course, the just like a pandemic or an outbreak. No, this is the fast traveling of misinformation, the spread of misinformation along people. And again, we've learned that misinformation and disinformation travels faster than nuanced, true information. And it's just that the architectures for misinformations are stronger and algorithm friendly, as opposed to, like, let's say you have an AMA representative, talking in broadcast media, posting a single video, but not really addressing, like, the comments. So you have that one. But the second is that I think there also has to be I think the physicians also have to concede that, lived experiences of disease also accounts for, true knowledge, right? And that patients, maybe they know and they should be sharing decision making. We'll talk about that when we go to the patient-physician interaction. But yeah, so again, the monopoly for medical knowledge in the algorithmic condition that we have now in, this digitalized society, in this datafied society, that has sort of crumbled and fractured the usual, high-held dominance that physicians used to have. And then, of course, we have the countervailing power of the government, right? So critically Light, we have Donald Light, and they argue that professional dominance was never fully entrenched. He views that medical landscape was in a constant state of flux. meaning it was never really that strong anyway. It's just that we had some temporary stabilization. There was only a temporary time in the 1950s, 1960s wherein, we view doctors as if they're better than our statesmen. But, eventually, when the government started creeping into the regulation, when insurance corporations, started creeping into what they could do in patients' bodies, and consumer advocates also sort of, put their foot in the door, and then suddenly this particular temporary stabilization of authority had been questioned, have been cracked, and now we're seeing those cracks, upend in real time. But also, there's also that concern about, self-regulation, about can we really trust, physicians to regulate themselves? Can we trust nurses to regulate themselves? In an ideal world, autonomy of professions are supposed to be protecting the profession itself, protecting the prestige of the profession, the scientific, coherence of that profession, the effectiveness of that profession in order to provide healing to their customers, to the clients, to the patients. And so we built, committees within these professions. We build committees in hospitals to be able to see when there are, fractures, when there are ruptures, when there are times wherein, professional standards are met, medical malpractice, medication errors are made, negligence has been committed, then, it is the professions, who's supposed to look at this and determine that this is wrong and we have to correct it. But in reality, and I've seen this also in my, when I was still practicing, that there is a code of silence that is being, there are doctors and there are nurses, there are health professionals, nursing assistants, medical aides, who really do errors in practice, but people cover up for them because, correcting is too difficult or could also be reputationally detrimental for the people who are involved. And so, it happens, right? It does happen. However, of course, slowly, particularly for patients who are able to, get legal impediment, legal corrections, legal reparations, who have good legal literacy and they have money for litigation, they pursue this. Particularly in the Philippines, though, I would argue that not many people know their legal rights, particularly their medical rights, and so what happens is that it's easier for professions to cover up, right? Their issues, right? So, of course, I wouldn't say the particular ones that I've seen, of course, but yeah, it does happen. it does happen. So yeah, and then of course we've seen this particular in the readings that we have this particular case study wherein a pediatrician faced 471 complaints, but the hospital failed to report him in the state board. And we can just imagine if, there's a very, very good doctor with new innovations, sought after, and then the only one who can do this particular, very specialized operation, and that person is abusive. Can the hospital really, is the hospital incentivized to report that person to the state board if that person is, let's say, a sexual predator? So these are some of the things that, this seems to be like fictional, but, they really happen in real life. Of course, I can't particularly give a particular case, but I'm sure somewhere, in our jurisprudence in the Philippines that things happen like that. But also, particularly in the States, there's also and this is something that I'd like to share, because again, no, in nursing, no, in the Philippines, we're being taught as if we're going to be exported in the States eventually. And then, our faculty members would always tell us, hey, in the Philippines, maybe you can get away with things when you when you F up in the work that you do. But in the States, they're going to be questioning everything you do, especially when you're working in a private hospital and you are, talking to middle income to high income patients over there, and they know their legal rights and they will sue you for things. And so that was one of the things that was, socialized among us Filipino nursing students. You have to know the legalities. You have to know. By the way, the way we're taught, negligence and malpractice are different, right? So when you say negligence, you weren't able to do what common sense would tell you that you should have done. So, if you were able to use your prudence, your common sense, then this would not have happened. So for example, of a negligence is that you know that this patient is frail and has a high fall risk, and you forgot, to raise the bed. You don't have to be a nurse or a doctor to know that you have to raise the bed rails for that person to not fall, but you forgot it anyway, so that's negligence. When we say malpractice, this is, not being able to do a specialized skill correctly, and that caused the detriment of the loss of life or loss of limb or loss of function for a patient. So for example, you left. For example, you're a nurse and you forgot to count the number of gauzes that is supposed to be taken out of the patient's body before he gets stitched up post-surgery. So that could be counted as malpractice, because that's a very specialized nursing. This is very specialized. But also in that context, the people in the surgical team also gets the fall. So those kinds of things. But again, what we see is that there are a lot of negligence and malpractice outcomes that that actually get sued, right? But what happens in the States, for example, is that because people are just easy, it's easy for them to access their legal rights, and attorneys really are really specializing in medical malpractice, and they would really advertise themselves as this happened to you, etc. I can help you get. And so what happens is that defensive medicine, defensive nursing now happens. And what happens is that doctors, so that they can cover all of their bases, they will order so many orders, like so many blood work, so many imaging works, so that they cover all their bases, because if they miss something and then they missed something, they could be sued. And so what happens is that the patient's expenses balloons, because the diagnostics is more complex, because the doctor is too scared of being sued. So yeah. And then of course we have seen that in the world of medicine, there's an increasing entry of women in the profession. But even so, that is of course within demographic transitions, but within the nature, there are still specific nuances. Like for example, women are more likely to be embraced more in OB/GYN and pediatric subspecialties. You wouldn't see them as much as, for example, quote-unquote masculine specialties like orthopedics or probably neurosurgery. Things like that. But also there are racial representation gaps, particularly in the States, wherein there are certain racial groups that are not well represented in the workforce. In the Philippines, medicine is really a middle to high income class profession, particularly because it costs it costs a lot to be a physician in the Philippines. And just like the Philippines, there is a concentration of doctors in urban areas and a lack of concentration in the rural areas. And this is the reason why in the United States, they have advanced practice nurses who do some work that doctors do so that these people in rural areas can get care. But that is also a big issue in terms of professional boundary work, because they're still contesting on who is able to do what, right? Because we have I'll talk about it when we go to the nursing part of this discussion. There's also something very interesting about how doctors are being trained, and I would say that this is also something that is also socialized within us when I was training as a nurse, right? So Renee Fox created this theory of, doctors or physicians being trained for uncertainty. And they're always told that there are three things that are true. The first one is that there is an incomplete mastery of available knowledge. For example, a person can, know everything. That's why we have specialists, right? In your 5 years of medicine, you will be learning general medicine. You'll be, learning the different areas of practice: radiology, pathology, gynecology, obstetrics, psychiatry, rehabilitation, pulmonology, etc. Then eventually, you still have to have extra, but you still have to have extra training for you to have like a very specific specialized thing. But you can't learn everything, and some of them you will forget eventually when you become more a subspec. You might forget or be less competent or confident to do, when you get. And then also, there is a limitations in current medical knowledge. Like medicine doesn't know everything, right? And when you have new medications coming into you might not know the side effects yet. Like for example, you're still knowing about whether Wegovy or the GLP-1 thing that we're using, right? While there are really promising, we still have to look at longitudinal effects, and there's still studies being done on that, but things like that. And then of course there's a difficulty distinguishing between the two. Is it something that I don't know, or does medicine does not know it yet? And then what happens is that when you're a physician, you have to be able to control certainty even when there are macro uncertainties that exist. You have to, again, because you are not just saving your face when you are facing the patient, and this is also true for nurses. If you don't know, you shouldn't. It shouldn't show in your face. It shouldn't show in your face that you are unsure of what you're saying. You are trained to pretend at least that air of confidence, because you don't want your patient and their caregivers to have some doubt on your competence, because that will also increase their worry about the outcomes of their work. So sometimes we are trained to pretend to know as if we know, but to act as if we know, even if we don't know. So we scramble back to the nurse's station, we scramble back to our offices, we kind of see, what do I do next? And so that's kind of the dance that we have to do with patients, and we learn about that in a while when we go to physician-patient interactions. Also, in the medical education, like the medical curriculum, the 5-year medical curriculum, even the Philippines is very much parallel to what we have in other countries. There is a sort of hidden curriculum. When I say hidden curriculum, this is the what is not written in the curriculum but is taught as a part of informal socialization, right? Like for example, nurses, you're supposed to be caring, you have to always be clean, you always have to be having a smile on your face, you always have to be empathic, right? So these are things that are, taught to us even if they're not necessarily part of the curriculum, but always has to be there. We always have to have that particular persona being being done. And this is the same for doctors. So what is that persona that the doctors are being taught to have? So first, detached concern. No, there's a supple balance of being objective and empathic, intellectualizing the body to function without emotional paralysis. So what happens is that doctors, because they have to be objective, even if they see a lot of trauma in front of them, they have to, keep it all together. And so that managing of emotions may be quite also causing secondary trauma for our doctors and our allied health professionals. So that's the hidden curriculum. And then there are values learned by observing superiors rather than textbooks. And that's another thing about hidden curriculum. Like for example, for physicians, there is a bigger focus on curing than caring, because again, because caring is usually relegated to allied health professionals, more specifically nurses, and so they're really more in terms of correcting what is wrong in the patient. And then, of course, depersonalization, and they view patients as cases or puzzles. And my gosh, you should. Right, guys, I've seen this play. When I was showing my students. When I was supervising students, nursing students in a very complex, hospital, in this very complex ward, and my students were looking at in horror when the consultant comes, and then all of the residents were there, and the interns were there watching, and then the consultant is not even looking at the patient, and then and they're like, so what's the case? And then they're reporting, and then parang visual aid yung patient, and my students were horrified, and sadly, this is what the patients also signed up. You wanted low cost medicine, be an educational object for our doctors, and that's kind of sad. For me, I also was, what? Why? And they're not even talking. If they're just talking because asking questions, but not really allowing a lot of room for the patients to talk, and they're talking like these are case in front of the patient and the caregiver, so objectifying, so dehumanizing. And yeah, I'm just saying that things that are happening and I've seen in the hospital. And then of course the slang, the cynicism is gomers, get out of the emergency room, or for example the Hama. There's a Hama. That's what we call in the Philippines, Hama. Home against medical advice. These are for patients who just want to go home, but doctors haven't discharged them yet, so you have to make them sign so that the carers or the physicians that are taking care of that person will not be legally bound to whatever happened if the patient goes out. So it's called Hama. So of course we have our own slang, and of course doctor, or for example, room number 7 is toxic, and so that patient is will require a little bit more effort for the nurse and the physicians working. So we have also our own lexicon when you talk about, and probably you've heard me talk about those lexicons in some of our sessions, right? But yeah, so we had our own lexicons, and these are things that we kind of shared with us. PRN, those are some of our PRN is as needed. Yeah. And I would also say that a part of hidden curriculum, and I've learned this, and some of my students who graduate as nurses and eventually got into medical school, and they were so horrified because their professors were telling them that the nurses were actually second-class citizens in the hospitals, in their face. What? So that's an example of a hidden curriculum, particularly the Philippines. I've been hearing these stories about how doctors are trained to teach nurses as if utusan. So, yeah. That's it. That's sad. But also, within the context of medical training, there's also that, hierarchy. You have the attending physicians or the consultants, no, who have more power than the residents, no, who have more power than the medical students, and the medical students who are below the chains, they were assigned the dirty work, they're assigned the paperwork, right? And they are asked to go to 36 hours of straight duty, which by the way is so inhumane. But that still happens nowadays, right? So, yeah. There's still sexism and gender discrimination that persists in medical, particularly in highly masculinized subspecialties. And then there is career dissatisfaction, no, for some people, unless they're really in good subspecs that really pay, but these are highly specialized, and it takes a lot of you have to invest a lot of your years, no, for you to become a neurosurgeon. You count 11 years for you to become a neurosurgeon. So, but yeah, this is what the payment for surgery is one car. that's the, but you have to invest 11 years for that. So yeah. And so looking at these things, practicing that stoic face in front of the patient, pretending that you know things that you don't know, practicing objectivity even if you're hurting for the patient, practicing that, being able to see all of this trauma, the burnout rates among doctors, particularly those in the bottom of the chain, like your medical students, your interns, and then your residents, 50%. I can just imagine 36 hours of straight duty. You just have 1 hour naps in between. And so no wonder, because the nurses are in the bottom of the chain. I remember being shouted out by some, poor medical students and residents who have to work 36 hours straight. Physicians have, higher suicide risks than most of the population, particularly in the States, when they, are always at the brink of, being sued. And then other things that increases their work is like doing desktop medicine. There's a lot of documents that needs to be filled out because of legal reasons to protect themselves. There's a loss of autonomy. You can't care for the patient because the patient isn't insured. Wala siyang pera din as well. And of course, sleep deprivation. Now let's talk about physician and patient interaction. Now, according to Talcott Parsons, as we remember in your sick role, being sick is a deviance, right? But it is a sanctioned deviance, particularly because you can waive some of your responsibilities, you can have extra rights as a person who is sick, but you have to be dominated by your doctor. And so the idea of Talcott Parsons is that the physician acts and the patient just accepts. But according to Friedson, right, this asymmetry, which is Parsons views as a sociological necessity, because these are person that needs to move from a deviant state to a functioning state. Friedson argues that it's not like that. This could be true, particularly for persons who don't have agency at all because they are in an emergency, they are in a coma, and they can't really fend for themselves at all. But for example, if a patient, like say, is experiencing an acute infection, doesn't really, have a large impact on activities of daily living, the patient still has their faculty for them to be able to think for themselves. Or if the patient is having a chronic illness like diabetes, when you have diabetes, are you a patient of the doctor forever? Definitely not. You have to live with diabetes for as long as you can. You have your neurodivergent. You cannot, just assume an activity passivity type of relationship. And so, according to Friedson, there are three. And what we're commonly looking at is the guidance cooperation. right? So the physician tells, the patient obeys. But at the same time, this is for acute illness, but what we want eventually, particularly for chronic illness, is mutual participation between the doctor or the physician and the client. Shared power, shared context. By the way, you would hear me sort of change my tone, no? So lately, we haven't been using the term patient anymore because patient, like I said, in the Personian view, feels a very passive, like just receiving care. And we're using the word client now because we argue that, they also have agency. They can also decide for themselves. And so we usually use the word client. But eventually, when you get to like really high accredited hospitals, they call them customers. So it's becoming more managerial, and you can just get a feel of how neoliberal managerialism, seeps into medicine in that context. But well, I'm more comfortable calling them clients because again, this affords them the idea that they serve service, but they also have agencies of their own. They have desires and needs that they can meet if they are assisted well. No? So the goal is to move the patient from activity passivity to guidance cooperation to mutual participation, and eventually if the patient can really do it on themselves, and maybe hopefully they don't need to contact the medical professional anymore. And then of course, again, we talked about doctors being stoic. And then, of course, again, you remember the case of, my students seeing the doctors and the residents in horror, treating the patient like a visual aid, a case with multiple disease, seeing the patient as a disease as opposed to seeing a patient or a client as a person. That's the medical model, But now we are seeing, thanks to Engel, in 1997, the argument is that, the person is not just a manifestation of cancer. The person is not a mere manifestation of tuberculosis. The person is an assemblage of biological, psychological, and social factors that, interact, that led the person to be in a medical institution in the first place. And, a part of that is the person's family, work, stress, and housing. And these also have to be attended to if you want the patient to be well, not just look at the pathophysiology of the individual. Although, of course, when there are subjects, particularly, I can just imagine, because when we do our medical surgical nursing during my days, we're very pathophysiological. We look at what happens in the cell when a disease is happening. You can just imagine how microscopic physicians go into that particular. And then we also talk about, pharmacology, when you drink a medicine, how does it get absorbed by the body? How much of it gets absorbed in the body? What is its mechanism of action? We study those things. But at the same time, Engel argues that, sure, we study those things, but also in addressing the client's concern, we have to look at not just the biological or the physiological manifestations or the physiological mechanisms, but also the social and the psychological factors that, brought this participant or this client in the medical institution in the first place. And then also, and we're going to ethics territory, there's an ethical tug of war that is always happening. Like, for example, the idea of do we afford autonomy for our, because it's your body, your choice, or versus beneficence. Like, if you don't want this medication, you could die. So that means I could knowingly cause your pain because I am allowing you. I cannot take your autonomy away. So which should I respect more? And of course, conversations around, like, if the patient is not able, or if the client is not able to talk for themselves, then maybe you need to work towards beneficence. But really, for autonomy, everything has to have an informed consent, right? For every form, particularly invasive form of like extraction of the blood, uh, any type of procedure, the patient has to consent. Sometimes there's not much time for, especially in the emergency ward, the nurses just show you this particular paper and they will just tell you, this is the, you have to sign this. Papirmahan nyo to, ma'am, kasi pag wala po ito, hindi namin kayo magagawa. Ganun lang, because high stakes, kasi nga kulang nga, meron tayong problema in terms of the number of workers vis-a-vis the number of patients, the patient ratio, the nurse-patient ratio, or the doctor-patient ratio. And so, yeah. And of course, the common example of this is, for example, is the Jehovah's Witness. For them, they cannot accept any form of blood transfusion. So even if it's the only thing that can save them, you cannot. But as long as this is, again, but you have to explain to the doctor that if you don't take this is the prognosis. It's really poor prognosis. We can just give you a lot of plasma, a lot of blood extenders, but if you don't actually get transfused, you might die, or the patient might die. And even if you give all of this information and the patient still says, I don't want to, there's nothing you can do about it. No. So that's the thing, right? And so that's important. They have competence, meaning they really are able to understand. Number two, they understood. You give them all the pros and cons of the situation. Like, for example, because it's easy for, let's say, surgeries. For example, before you get into surgery, that's supposed to be the last that you have to take, right? So, guys, if a doctor says immediately the thing that you need to do is surgery, ask for a second opinion, because because surgery is a difficult thing to recover from. So if you can not do surgery yet, you have to try the pre-surgery first, right? But if you need to get to surgery because there's no other way to address it, then they will give you these pros and cons. Now, there are really more straightforward surgeries, like cesarean sections. Like the success rate of this is super high. So, like, confidently, the doctor can say, yeah, you'll survive, the prognosis is good, etc. Laparoscopic cholecystectomy, or removing the gallbladder, that is also sort of a routine surgery. But there are some surgeries that, you need to really weigh the risks. Like, for example, in my case, I had an impinged nerve because of an herniated disc, and I was so frustrated because the three doctors that I met, they all didn't want to do surgery on me, but I was already semi-paralyzed and I didn't want to. And then even the top neurosurgeon didn't want to operate on me. And eventually I learned, and then the last doctor told me, you know what, you're lucky that you met with me, because if you go to this particular hospital and you show this to an orthopedic surgeon, they will eventually offer you to be surgeried, and I don't want to do surgery on you yet because you're still young. I was 25 back then, and they just said, continue your physical therapy, drink your neuropathic meds, and let's see what happens. And I got better, good Lord, and because of but the risks of that surgery, if I did have to take it, is like 1/3 I get better, 1/3 chance that nothing happens, and 1/3 chance that I can get paralyzed. Just imagine it is in the neck, and the doctor could do something wrong, and not really do something wrong, but it hits a nerve, an important nerve, and I wake up and I'm paralyzed already. So, and these are some weeks that you have to sign off before the surgery gets into place. And so, yeah. So, those are the things. And then, of course, voluntariness. Like, is this really their own volition? So those are some of the things that you have to consider when you talk about these types of ethics. Now, why do patients feel like they're not being cared for by the doctor when they see the doctor in the clinic? Now, there are many factors that have been, identified by social scientists, and the first one is the setting. Lack of privacy, uncomfortable privacy environments. You imagine like a very crowded emergency room, and you are only seen by, there's a lot of people around you. You're also distracted, and so you're not able to say a lot. Time constraints, like an average visit to the doctor is 13 to 16 minutes. And then the arguments that, the physicians interrupt a patient's opening statement after an average of just 11 seconds. Sisingit na agad yung doctor. Diba? Because nagmamadali si doctor kasi marami siyang patients na kailangang kitain. At lagi pa siyang late because nagbi-bleed into siya from a previous extended duty from a different hospital. And then, of course, the language gap, like medical jargons like edema, or NPO means nothing per orem, meaning you're not supposed to eat anything or drink anything. MI means myocardial infarction, or a darker or a more complicated form of heart attacks. And the control style in that communication is that the physician talks down. Not because the physician probably wants to talk down over you, but it's just the physician wants this done as early as possible. Not because they don't want to see you anymore, but it's because there are a lot of patients on the line supposed to see you. It's also the same for nurses, right? If you have like for example, in PGH, you have 4 nurses. Each nurse is taking care of 10 patients. Can you expect really a nurse to do like full bedside care for the patient? So those kinds of things, right? So if there's too much work being done, it's really, it really detracts, a good patient physician-client relationship. And also, SHIM forward the idea of cultural health capital. Doctors usually take clients more seriously if they have cultural health capital, meaning they know their medical vocabulary, they have a proactive disposition, meaning they know their options, they ask questions about the options they have bureaucratic know-how, meaning they know how the hospital works, and so that comes with social privilege. And so sometimes when the physician, when I am talking to the physician, I usually act like a normal patient, but the physician tries to like patronize me. I start, giving out. I start showing my cultural health capital, so that okay, this person isn't someone, and this is someone who knows their stuff, and so I cannot just pretend and stuff. So, and patients or clients with high capital navigate the system more efficiently, without being marginalized by the enterprising demands of modern medicines. And sometimes I ask usually, like, for example, I had a very severe case of migraine. I thought I had a stroke, and so I think the neurologist who I was talking to really didn't think I had a stroke, but in my mind, it might be a stroke because it was such a very bad experience. And so I was telling them, I want to, these are the things that I want. And then I told them, do I need an MRI for my head? Magnetic resonance imaging. For my brain, did you want to see my brain if you just to rule out that I didn't, get stroke? And the doctor was like, no, maybe not yet. Maybe we have to look at like other blood labs, because maybe the doctor didn't want me to like pay. And so parang a week after I saw the doctor, nothing came out, and like the doctor was seeing me visibly still like, please, let's just check if I have a stroke. Order an MRI for me. And I now understand why the doctor didn't want me to like have the MRI so hastily because it cost 20,000 pesos. But I was so scared for my life, so I took it anyway. I spent 30 minutes inside an MRI machine. I'm already used to it because of my spinal injuries. And apparently, I just took a selfie of my brain. Nothing was really happening. And now it makes sense that it's really just a very, very severe case of migraine. And, yay, I don't have a stroke. But I lost 20,000 pesos. So, but yeah, the doctor is able to kind of, talk to me a little bit more confidently because, and really talk me that maybe you just, hypochondria lang yan. Hypochondria means, you for a lack of for a lay saying of hypochondria is that you overthink about the symptoms that you have. You always think you diagnose the worst. You self-diagnose yourself for the worst. And then there's what we call cyberchondria, meaning you're looking at the internet for your that's my thing. That's my go-to problem. Don't do that. No, don't be like me. So yeah. So that's cultural health capital. And then of course the identity of the physician and the client also influences how we deal with them. Like for example, women physicians are more likely to have longer talks with their patients. Two things. One, it's because probably they're socialized to be more caring and more attentive to the emotional needs of people because they're socialized that way. Also, number two, they may not have that much patients as male doctors would have. Next is the patient's gender. Women who are presenting heart disease are often treated less aggressively due to atypical symptoms or being perceived as emotional or being perceived as that's you going through menopause. But, heart attacks are usually atypical for females than males. And then, of course, the LGBTQ, body disruption, high rates of misgendering, high rates of transphobia, lead to avoidance of care, particularly in where being transness is considered a very negative social identity in a particular society. In the Philippines, we may not be as bad as the States, but of course there's still a lot of legal problems and there's still a lot of stigma that is happening. So what happens is that trans people, for them to get trans-specific care or trans-affirming care, they have to go through outside medical institutions for them to get what they need, and sometimes that could be harmful for them. Now, there's that conversation of, let us not use the word the patient is compliant to their medications or to the orders of the doctors, because when we say compliance, if the patient was not able to drink their meds, we always say it's a deviance, right? Parson says you're malingering, right? You're not following. The society has waived your right, your responsibilities. You have a right to not work. So your responsibility is to get well. If you did not follow the doctor's order, you are a deviant patient, sabi ni Parson. But now, in the context of adherence, we don't use the compliance anymore, no? We use adherence or concordance, no? But we do know that that's not. One, because cost. Baka mahal yung gamot. Or job constraints. Like, I cannot really rest. Because if I rest, if I take off time work, then I would lose income. Family roles. And rational response to constraints. Like, I forgot my meds, etc. And so what we do is, we activate the patient. So we move from obedience to, making the patient more health literate. Right? Give more self-care agency. Right? Give them more, to afford them more agency for them to take care. And so patients with low activation have 2 times hospitalization rate. So if they're not activated, if they're not concordant, they will go back to the hospital for a worse or it's either an unresolved medical issue or a worse issue or a complicated issue. Now, let's move to the nursing profession. Now, when we talk about professions, there are four ways for us to be able to talk about it. Now, sociologically, the first one is historical, which we have seen earlier in the way we traced how medicine gained its dominance and eventually its slow downfall again. We can also look at structural, like its traits and institutional forms, when we talked about how professionalization, etc., how you get licensed, etc. It can also be functional, like what its role in society. So, for example, in a Parsonian model, the medical institution is supposed to be the ones making deviant sick patients to become well again. But also, another way to look at it, based on Andrew Abbott's work, is a systemic or a systems view of professions. And that's what we're going to do when we look at nurses. And so, again, one of the things that is a very long struggle in nursing is that it is going through that river of, are you a vocation or are you a scientific profession? Even within the profession, there is that connotation that we are a vocation, but also we are a profession. And so when somebody from the outside, your client, for example, sees you and you're not doing a work that is very priestly or very, very holy, then they would say, are you really a nurse? Because you don't act as if this is your vocation. It's as if you're acting out of this because you need money. And so those kinds of conversations. Also, at the same time, other professions would look at us and say, yeah, but you are like maidens. Like, ugh, I hate that. But there are still those connotations and discourses within the medical field. And so we, again, go back, right? So, why is nursing a profession? Because it has specialized knowledge. It has a professional culture with standards and, it's service-oriented. However, it has autonomy within nursing, but not outside nursing. Like the professional boundaries, it cannot really expand its territory as much as physicians can, for example, and authority as well, right? So, an example would be, for a long time, nurses in the Philippines have been trying to have an advanced professional nurse role, meaning they could do some of the things that doctors could do, particularly in spaces wherein there might not be doctors present. Like, for example, give anesthesia of a certain dosage. So there are conversations like that, but the doctors wouldn't give their scope away in the Philippines. And even in the States, no, it took some time. Now, what are the other systems, professional systems, like, sort of constraining nursing jurisdiction? One is, the medical monopoly. We've discussed this already. State control. What can the nurse do and can't do legally based on governance, right? So, I want to define what a nurse is, but we have changing definition. But basically, what we do in the most easiest sense is that we diagnose and we address actual and potential human responses to medical problems. So our goal is to look at human responses to medical problems. The medical problems, the curing part, that's for the doctors. The caring part for the nurses. So yeah. But of course, professional-wise, there are checklists of what that means. Carrying out orders of doctors, providing, getting vital signs, etc. So there are a lot of scopes that we do based on a particular area of practice we have. And of course, bureaucracy, hospital hierarchy, and structures. Ang head, I don't know if there's a CEO of a hospital who's a nurse. It's almost always a corporatist or a doctor. Right? So it's a medical doctor that oversees everything, right? Siguro the highest that a nurse could be in a doctor is a senior vice president for nursing, but not really the full hospital. Probably research, probably informatics, but not like the whole hospital. So doctors wouldn't really be happy being being headed by nurses, right? So, and then there's also the intra-professional conflicts. Like, for example, it's nurses themselves say that, yeah, we are a vocation. We're supposed to be helping one another. We're supposed to be, self-sacrificial. Those kinds of things. Yeah. So that sort of constrains the autonomy and the authority. We do have that, but it's constrained. No? It's not really X as in X. We do have that because we are a profession, but it's just super constrained. In the States, they have different types of nurses. They have the licensed practiced or nurses, so they do supervised basic care. In the Philippines, we don't have this, but we do have nursing aid assistants or nursing aides. So these are pre-licensure nurses or, technically trained people who are able to do less specialized tasks like take vital signs, probably support the patients, move the patients from one place to another, etc. And then we have the registered nurses. This is basically of course, this is median pay $71,000 in the States, but in the Philippines, that's already a lot. But in the Philippines, we do know that we do not have a lot of that, right? Do you remember? And then, of course, in the States and in other countries, they have advanced practice nurses who can do some scope that the doctors can do, particularly where doctors aren't found, for example, in rural areas. In the Philippines, that could have been very helpful for areas that they don't have concentration, but they don't have concentration of physicians, but physicians won't really want to see their power. So so that's an example of sociology of professions for you, my friends. The dominant professions don't want to see their power. Anyway, let's move on. Interestingly, in the nursing profession, there's still an increasing, it's a feminized profession, but there's an increasing amount of males, me, who are taking the profession. I was told that, I think being a male nurse, gets you further in the profession because you're, I don't know, at least I was told you're more favored because you can, carry people. So masculine, very masculinity oriented, conversation. But it's interesting because being male, according to, or being a man in nursing is, instead of having a glass ceiling, they have a glass escalator. Males grow faster in the profession than females. And I can see it in the Philippines. Like, I do know a lot of chief nurses who are males. I do know a lot of professional organization heads who are males, right? And I don't know if this is a thing about, subordination of feelings, but this is more about, female nurses who are helping their males to get further, right? So they call it a glass escalator. Being male in the profession is a glass escalator, at least in the States, but I see it a bit in the Philippines. Not to say that the colleagues that I have who are males and also who are chief nurses are bad or are not really better than the females. It's just that it feels like because their maleness sort of gives them a little bit more privilege, so that they can get to these particular high spaces. And even within the nursing profession, there are class stratification. Like, for example, your RNs, feel more privileged and, dominant over auxiliary and ancillary nurses or auxiliary nurse assistants. So, and of course, what's the human cost of all of the burnout, of all of the secondary trauma that nurses go through? And that's emotional labor. Nurses are the 5th highest occupation for musculoskeletal injury. Imagine all of the carrying that we have to do. And we're taught of how to carry patients who are immobile. We have to turn our patients who are immobile every 3 hours. And of course, emotional toll, constant exposure to death and silence grief. And I remember, when one of the patients that me and my students were caring for died, was the first time my students sort of watched a death for the first time. I allowed them to cry, but like the nurses in the hospitals were like, why are they crying? Like, why are you supposed to cry? You're not supposed to see. You're supposed to see death, and you have to be calloused. And like, give them a break. It's the first time they've seen a death. Please give them a break, please. Anyway, but yeah, this is something that I personally dealt with. When I was, I had a duty in a hospital, in an ER, and like in a shift, I saw 8 patients die. I saw 2 patients. One of the patient was the holdupper, and the other patient was the victim. And the holdupper, who also got gunned down by the police, survived, and the patient who the holdupper stabbed died. And like, for me, it's like, that was such a, sorry, trigger warning, that was such a very emotionally tasking. And of course, my faculty, my clinical preceptor didn't really sort of debrief me on that. I had to go home and like process that on my own. But like, yeah, but these are the things that we experience on a daily, right? And so what happens is that, burnout, exit. In the Philippines, high turnover rates. In the Philippines, we stay for a year, 2 years in the local hospital, and we leave in the States. And in the States, we feel so much better because we've experienced the worst cases in the Philippines, the worst patient ratios in the Philippines. So when we go to the States, and the patient ratio is like 1:3 for the nurses there, it's crazy ratio. In the Philippines, like, I'm used to like 1:15. So like, this is like easy for me. And so Filipino nurses can do 2 shifts because like, we were trained for this, no? So that's the reason why there are a lot of Filipino nurses elsewhere, as we see in this chart that we've discussed already in our 3rd session. And who else are in the allied health professions? Let's not forget them. We have the osteopath, or the DO. We don't have that much in the Philippines, no, but this is an example. Osteopathy is a particular form of complementary or traditional medicine, but it's gaining more professionalization in the States. We have the physical therapist. So the goal for physical therapists is for them for rehabilitation, no? To make sure that the patient is able to be able to gain their physical abilities, no, after being ill. But at the same time, they can also do preventive. Now, the issue with physical therapists, which I notice, is that there is some boundary work that they have to do with exercise scientists and exercise professionals. So I see a lot of conversations online about like, why does the professional organizations don't call out this seemingly poorly prepared exercise gym instructors for fly-by-night who might cause injuries to the patients, etc. We also have the podiatrists who are specialists for the foot, ankle, and lower leg. Particularly, this is good for those who have diabetes because of gangrene, and etc. We also have, of course, the dentists. And we do know that dental care is very important because that is one of the causes of absences, no? Dental care is, of course. We have, of course, the vision care. So we have the ophthalmology, who is the MD for surgery and disease, the optometrist, who tells us that you have this grado in your eyes, and then the optician, who does the fitting and the dispensing. Then, of course, we have the pharmacy, the provider, found in drugstores, in community drugstores, and in hospitals. And they're vital for safety checks and the patient education for for medicines. Sorry we don't have a lot of PharmD or doctor pharmacy in the Philippines. I think there are offerings, no, but we still have to professionalize this. They're not much, except of course we have Dr. Arshi, no, who's doing a lot of pharmacy education, pharmacological education online. But they're still yet to have more of PharmD so that, you know, we can really place where they are in a particular setting, aside from academe, of course. And we have, of course, psychology for the mental health. We have child life therapy, who, you know, for family, etc. You have pharmacy, physiotherapy or BP. You also have your occupational therapist who like works on activities of daily living and fine motor movement. You have social workers who connect, you know, patients to help just in case they need it. Counselors, OTs I mentioned. We have radiography or radiological technologists, no, who assist. We have the orthoptics or the opticians. We have the radiation therapy. Sometimes these are nurses as well, no. We have other therapies, art therapy, music therapy, etc. We have speech pathology, who, you know, for example, you got the stroke and then it affected your speech pathology. These are speech pathologists are, you know, small number of professions, but they have a large clientele. Nutrition dietetics, no, for nutrition counseling, etc. Exercise physiology, and of course podiatry, as I mentioned. And so the future of health is more flattened, right? So at the moment we see domination of physicians in the healthcare chain. What we want to see, physicians, integrative therapies. By the way, my beef here is that, you know, for example, acupressure, acupuncture, these are, you know, proven care, at least in traditional Chinese medicine hospitals in China. They really do have scientific studies about this. But, you know, I can remember like biomedicine sort of biomedicalizing this. I'll talk about this a little bit more later. But yeah, this is why I hate it so much. I hate, for example, a doctor saying that, you know, it's safer to have acupuncture with me because I'm a doctor instead of a pure acupuncturist. That's a problem. Osteopaths, pharmacists, and nurses working together, no? Flattening the hierarchy, integration of the practices into for health, and rising education requirements across all fields, and also making sure that they're paid well. So thank you so much. That is our session for today, and I'll see you for the last session next week.